one of the only places that you can actually see these fasciculi. And it makes it, it starts, to me, this is what really helps kind of this to begin to make sense. And that's with the optic tract. So I tell you on there to look at these fasciculi and see if you can trace them and track them down. So I was going to do this one because I was doing the other groups and some help them, so I'll put it up there. Right. So here's my midline. There's my midline, right? So when you look at your visual field, look at the eyes. They're set off to the side, right? And the optic nerve does not line up with like where light would be coming in, right? You would think that light would come, it's going to come in theoretically straight back, and there's the fovea. So when you're learning to do your fundoscopic exam, right? You come in from the side, you look for the red reflex, and then when you find the red reflex, you're looking straight back. Why do you come in from the side, and then you look straight back? What's straight back? Right? You're not going to see, if you're looking straight back, you're not going to see the optic nerve, you're going to see the macula, the fovea and the macula.
Yeah.
Right? And just medial to that is going to be the optic nerve. And why is that important? What is the optic disc? It's where the optic nerve is, where all those ganglia are going in. The optic disc is blind spot. You can't see nothing there. So do we want the optic disc directly back behind the lens? No, that would be kind of silly. So that's why it's kind of made this way. What this means, though, is that right? So what that means is I actually have two parts of my visual field, right? I can see, and this you're going to learn to do this on your physical exam, right? You're going to ask them to find where the and you do the white, right? So roughly, our visual field looks something like this, right? Mm-hmm. And you can have them close their eyes and locate your finger, right, with contralaterally, right, and then close this side, go over here. And now what I can see is that in this space, right, so somewhere basically in this space, I have true binocular vision, right? Outside of that, it's monocular vision, okay? So this is kind of the way the visual fields work, right? So when you think about light coming into the retina, right? Obviously, we're trying to move the lens, and of course the cornea is already shaped. We're trying to move the pupil and the lens so that we direct that beam of light right back to the fovea. Okay? Obviously, light travels all over the place. It can't all go right to the fovea, so it's going to hit the retina all around as well. Okay? So the way that we kind of think about this is that light, it comes, it's coming to the eye, and it comes in the eye, like such, from the left visual field. Right? So my left visual field, to the left eye, it's coming across the left eye, and it hits the nasal ganglia, right? And that's where that information is going to travel on those nasal ganglia, right, in the optic nerve. That same visual field, information is coming across the eye, and now it's not hitting nasal ganglia, it's hitting temporal or lateral ganglia, right? Here, right? That information is going to coalesce, all those ganglia come together, and they're going to travel through the optic nerve. Okay? Now, that's my left visual field. So what's happening with my right visual field? Same thing. The right visual field is coming across the eye, so that my lateral or peripheral vision, right, is actually crossing the eye, and it's going to hit on the right eye. It's going to hit in the medial ganglia or the nasal ganglia, and then travel medially. Right? Same thing as before. It comes across the face. Right visual field to the left eye. It hits now my lateral or temporal ganglia in the left eye, and then travels out laterally. So what I see is that I have essentially two two parts of my visual field, right side, left side, right? And of course, everything in the binocular field is going into both eyes, right? Theoretically, we're trying to direct all that to the fovea. What happens though is that we see that because light moves, across the eye like this, now we've got my blue and my red, right? My right and my left visual fields on opposite sides of the brain, so to speak. I know we're not in the brain yet. And so, typically, when we think about all the sensory information coming into the head, right, or motor going out, it's like right and left, right? Right controls left, left controls right, or whatever. Well, that's not the case here. So what has to happen? Right? The information that comes from the periphery comes across the eye and hits the medial retina, right? That information comes to the optic chiasm, right? And in the optic chiasm, only the medial ganglia, or that information from the peripheral visual field, will decussate. Why? Because it's going to move to the side where the same visual field is actually on the lateral optic nerve from the other side, right? And so it needs to get over there to be together. So the right visual field in the left eye, that information is lateral and it stays lateral. It does not decussate in the optic chiasm. So now both of those guys, look, I've got, now my red is together. Both of those guys are going to bounce out. And you can actually see those fiber tracks here, and it's going to find the lateral geniculate ganglia here, and they're going to bounce over here to the lateral geniculate ganglia. Once I reach the optic chiasm where that information decussates, I now no longer have optic nerve, I've got optic track. Okay? Same thing's going to happen with my left visual field. It comes to the midline, my medial ganglia or my nasal ganglia, approach the midline in the optic chiasm, they decussate to join up with the lateral ganglia here from the right eye, and they're going to bounce out, and then they're both going to find the lateral geniculate ganglia on the right side. What you notice now is I've got both my blues and both my reds together, which is what I want. Okay? You can see back here, so remember the head's slightly tilted here, that's why it doesn't look, perfectly uniform. But if you look back behind the lateral geniculate ganglia in the on the red side, right, then you can actually observe how there's white fibers leaving that lateral geniculate ganglia, and they're actually going back to the cortex, the occipital cortex. So that's what's happening, is they're going to move now, right, to the calcarine cortex. And the way that this happens is, right, it's going to kind of spray to the cortex, either leaving the lateral geniculate ganglia, moving superiorly up and then down to the superior calcarine cortex, or inferiorly down and back up to the inferior calcarine cortex. So what happened? When we were in the optic chiasm, the optic chiasm then divided my visual field into right and left halves, right? So what's happening back here in the calcarine cortex? The calcarine cortex, because I've got information that's coming, superiorly into the superior cortex, and the dotted lines, kind of coming down into the inferior calcarine cortex. That's not crossing midline. That's just going down and back up. Now I've divided my visual field into what? Top and bottom. So how many parts to my visual field do I have? 4, right? So I have 4 quadrants of my visual field, right? And if I understand this, then, on a physical exam, right, it's really nice because I don't have to have this picture. I don't have to go probing around their brain. I know that these are hardwired fasciculus. You can't change the hard wiring, but you can cause problems and lesions. So, for example, you have a lesion here, right, in the optic nerve. What happens? Yeah, you're going to have a bilateral blindness. A unilateral blindness, right? Loss of sight, right? In the right eye, left eye. Sorry, right? Loss of sight. What if we have, right, a a lesion here in the optic chiasm.
Both of them?
I'm only losing what? I'm only losing half of my visual field, because that's where it's divided in half. Half my visual field, but on both sides. So track it back. Where's it coming from? All right. In the right eye, that is lateral vision, peripheral vision. In the left eye, it's peripheral vision.
Oh.
Right? So I've lost my peripheral vision. I've lost lateral visual fields on both sides. They're both lateral. Right? Which means it's not right-sided or left-sided, it's lateral. So you can call it either bilateral or bitemporal, hemi, half, and not opsia. Bitemporal hemianopsia. Right? And that's what you have when you have an optic chiasm lesion. Most common cause of lesion there is going to be a pituitary adenoma, because what sits right below the optic chiasm? Pituitary. It's encased in bone. Has nowhere to go. As that tumor grows, where does it go? Into the optic chiasm and causes a lesion in the optic chiasm. Right? Now, what if you have lesion here in the optic tracts? Now I'm only losing red. How many parts of the visual field do I have so far if I'm back here? I have two, right? I've got right and left halves, right? So I'm only losing red, and I'm only losing when I only have two parts, right? So it's gonna be a hemi problem, not a quadrant problem, right? So it's hemi what? Well, it's only red, so I got to look at where red came from. It's from the right visual field, right, coming across the eye, right? And so it ends up being, if I'm thinking about as I'm looking, right, and if I'm losing my right visual field, then in my left eye I'm losing, right, this vision that's coming across. Mm-hmm. So the whole left side of my left eye is black, right? That same information from right visual field is coming in nasally to my right eye. So my whole left side of my right eye is black. It's left side in both eyes. So therefore it is homogeneous. Homogeneous, right? Same stuff mixed together, right? Homogeneous, right? Hemi, half, anopsia. You have a left homogeneous hemianopsia, right? Or hemianopia, depending on what kind of suffix you want to use. All right? When you get back here to the optic radiations, though, remember the optic radiations, some go up and some go down. All right? So if I have lesion here, then what's going to happen? I'm losing, right? I'm just blue. So that means I had a homogeneous, right, hemianopsia, except for the fact that now I'm past the lateral geniculate ganglia, so I only have what? Upper or lower, right? Depending on which side is affected. Upper calcium cortex is lower visual field. Lower calcium cortex is upper visual field, because we have a biconvex lens. It flips things upside down. As images are portrayed to the back of the retina, everything about, you're actually seeing everything upside down. The cortex flips it back up for you. Okay? So, here I'm going to have it's going to be, the right side of my visual field in both eyes, but not the whole right side, only upper or lower right side. So I'm going to have right upper quadrant is black in both eyes. That would be a homogeneous, right? Or a right upper homogeneous quadrantinopia, because it's quadrant, anopia. Can't see one quadrant, right? Jesus. Right, upper, homogeneous quadrantinopia, or right lower homogeneous quadrantinopia.
I didn't know
right?
this. Quadranopia? I can't even say it.
Yeah.
Quadranopia? What? I can't even say it.
Quadrantinopia. So quadrant, and then anopia.
Okay, quadrantinopia. Got it.
Right upper homogeneous quadrantinopia. Looks good enough for me. Yep. All right. So the cool thing about this is that you can actually see this pathway here. So I'm going to erase this, so I hope that's okay with everybody. So if you watch right here in the optic chiasm, watch the optic tracts leave the optic chiasm, right? And you'll actually be able to see them bounce out, right? Here's those white fiber tracts, right? They're coming right, they join, they're coming right over here. And so then they come in right here, which means that this area right there, right, is going to be my lateral geniculate ganglia, right? That's going to be the ganglia, right, that's controlling, or that my vision is coming into before it goes in the optic radiations. You can actually see optic radiations here, okay? Then if you look back at like this this little guy here, then what you'll find is, we look at, like this, for example. How is it that you can have, when you shine your pin light in one eye, your left eye, patient's left eye, both pupils constrict? How is that? Because I only have information coming into one optic nerve. I'm not shining in both. It's only one optic nerve.
It's all connected.
What?
Because it's all connected.
How?
Is it the chiasm, optic chiasm, or no?
Science. Right? So, if we think about like light has come in, in here, right? Went to the optic chiasm, some stuff bounced around, or whatever. It's coming out here to the optic tract. Here's my lateral geniculate ganglia, right? Everything so far, it's all one side, right? So, how do I get a motor reflex in my right eye? I have to get sensory to the right side somehow. So this is what happens, right? Here in the lateral geniculate ganglia, not all of that information goes to the lateral geniculate ganglia. Some of it actually comes right down here to, what do we call that thing that's in the back of the midbrain in the tectum that has the visual reflex? Superior colliculus. Good job. Right? The superior colliculus, right? In that superior colliculus, right, on that side, information is going to go here to the superior colliculus on the right side, but we also have some, right, that's going to go to the left superior colliculus, which means what? Now I have the ability to, right, from here, from superior colliculus, there's a special ganglia called the EW ganglia, or the EW fasciculus, that actually travels with cranial nerve 3, right? But cranial nerve 3, we say cranial nerve 3 does the pupil reflex. No, it doesn't really do the pupil reflex. It's really a special fasciculus that just happens to travel with cranial nerve 3 and is indistinguishable from cranial nerve 3, but leaves this area, this superior colliculus, right? And so I'm going to have motor, right? This nuclei is coming to the ciliary ganglia on both sides. But now that I've actually got information, I've sprayed information to both sides, right? Shining the pin light in one eye should cause a consensual reflex in the other eye, right? So if that doesn't happen, if I shine the pin light in the left eye and I don't get a response in the left eye, but I get a response in the right eye, you know where the lesion is, right? If I shine it over here and I get the response here, but I don't get the response here, I know where the lesion is. If I shine the light here and I don't get a response here, right, but I get it over here, shine the light over in this eye, I get a response here, but don't get it on this side, I know where the lesion is, right?
So
because
right here, both?
I know where that stuff crosses over. And this, of course, is a prettier picture of that, right?
Dr. Stone, so the lesion would be more on this side or towards the
So if I shine the light over here and I don't get that reflex in this eye, that means that the sensory, this sensory limb is messed up on that side. But if I get it over here, this one has to be intact.
Got it.
Right? If I shine the pin light over here, right, and I don't get the reflex over here, and I don't get it over here, that means that it's messed up somewhere back here.
Okay.
Both eyes are affected, right?
Makes sense.
You can also have, and then it gets really weird because you can also have right? Where you have an eye that you shine the light over here, no reflex, you get it over here. Shine the light over here, get it over here, no reflex over there. But person has full accommodation, which is weird because you would need to have your pupils constrict and dilate and the ciliary body to be able to control the lens in order to accommodate, to see. So how do you accommodate? Accommodation comes from the cortex, right? And then travels with that nerve to the ciliary body to then control the shape of the lens, the shape of the pupil. So if they can still accommodate, in other words, they have good visual acuity, cortex is okay. It has to be just down here in this nuclei. Makes total sense. Yes.
Dr. Stone,
Yes, ma'am.
what was this called again?
That's it's the superior colliculus. It's those are tectal nuclei in the superior colliculus.
And that's
But-
why
Thanks, man.
it dilates in the other eye that you flip the light.
Yeah, technically, to be in all honesty, it's not really the superior colliculus. It's nuclei right in front of it, the pretectal nuclei, but it you can see it. It looks like it's essentially the superior colliculus. So I say that because it's easier. I don't want you to have to memorize all the other nuclei, but you can see like in this image that the nuclei are right here, right? So this information, it comes in and it goes to that nuclei. So that's my pretectal nuclei. What's right behind it? The superior colliculus. So there's the pretectal nuclei, right? And that information then it comes here, and I get information that leaves that nuclei, goes contralaterally, leaves this nuclei, goes ipsilaterally. So now I have that sensory information shared to both of my EW fasciculi, which then you can see, like if you watch that, it comes up here, and it then just travels with cranial nerve 3. And actually, maybe there's another one. Let's see if I can. No, there's another image somewhere where it has, anyways, what it shows like it actually it just runs with cranial nerve 3, and that's why when you say cranial nerve 3 is the light reflex.
Okay.
Dr. Stone, do you have anything to know?